Welcome,
Thank
and
you.
I am so delighted to have you here with us today to hopefully clarify some of the concerns around trying to conceive
Mhm.
during the time of COVID.
Yeah.
So, for everybody who is just tuning in, I
Mhm.
want to introduce myself. My name is Sadie Minkloff. I am the founder of Sage Acupuncture, where we practice holistic reproductive health. And one of my dearest friends and colleagues is here with us today, Dr. Natalie Burger from the Texas Fertility Center. And we are just so honored and excited to talk to you because there has been so much confusion and differing information as this COVID-19 pandemic seems to change rapidly day in and day out. And so I'd really like to sort of get some answers to common questions answered today with you. So welcome and thank you for being here with us.
Well, thank you for having me.
I'm getting the most questions about is really just that we know that the American Society of Reproductive Medicine has considered, fertility not an elective. It's not considered an elective procedure. Um, and the World Health Organization and the American Medical Association have also said this. So, given that ground, where do we go from there now with this pandemic where connecting with people may not be safe? And so that's where I'd love to start. And then if we can continue into more specifics about our local area in
Mhm.
Austin, Texas, and how that might differ from other places that the ASRM is recommending their guidelines for.
Yeah, for sure. I mean, certainly, first and foremost, we are concerned about the health of our patients, our staff, and the community at large. So there's no question that that's something that we have to take in consideration. We understand that this pandemic has obviously disrupted a lot of people's lives in many different ways. And we have to, any kind of action that we take has to be keeping in mind, again, first and foremost, the health of our patients, staff, and the public health. We also understand that infertility is a disease. And if the treatment of that disease is delayed, then there can commonly be some consequences to that. In some scenarios, there may not be consequences, but in many scenarios, time is of the essence. And sometimes time is of the utmost essence in terms of fertility treatment. And so we feel that if we are trying to protect, the health of our patients and staff and public, we also have to understand the emotional health of our patients, what they're going through if they've already had challenges, with the disease and fertility and been told that they may need assistance, or if they haven't even seen anybody and are simply struggling, to conceive, that's already, a challenge to their emotional health. And if we delay significantly intervention and treatment, we may be taking away the opportunity of them having a family the way that they were intending or hoping to have. And so we strongly feel that our patients deserve our support right now. And again, like you were mentioning, infertility is a disease per the World Health Organization. So we are doing something to restore normal functioning of the human body. Procreation is a normal life process, and we cannot ignore that even during this time. So there's no question that we are taking precautions. There's no question that we are counseling our patients. And some of them may choose to delay, testing and treatment, while others, based upon what they're being told, may choose to continue to proceed. Every situation is different, and I would not say there's one size fits all. And even clearly in the United States, obviously, we've been, affected asymmetrically. I realize the American Society for Reproductive Medicine has issued their statement, and though we respect, what they have said, technically we do disagree with some of the elements of their message. And we feel like we can do both. We can take, safety precautions as well as, provide fertility assistance for patients and couples so they're able to succeed. Whereas if they delayed too long, they may not be able to.
So we've had a few questions on sort of helping people figure out where they fall in
Mhm.
that spectrum of cases. Is there some sort of guideline that we can, like, clearly people who have been diagnosed with cancer, who
Mhm.
need imminent care, but for some people that isn't quite as clear. Do you have any guidelines to help people figure out where they fall along that line?
I mean, it's true that a lot of it has to do with the age of the female patient. So if there's a female patient involved in the equation, then technically keeping in mind, her age group and knowing that the older someone is, the less time is going to be on their side. Though even sometimes we have had young patients with low egg counts as well too. And so we can't completely ignore that. But I would say that typically the female patient's age would have one of the biggest uh, reasons for us to want to go ahead and move forward more quickly. Um, Also, like long-standing infertility, that's something that is likely not going to improve just with more trying at home. It may not have quite the same time essence as low egg count or diminished ovarian reserve, but that's something also to consider. I think that, it's helpful to talk to a fertility doctor to sort of understand, based upon someone's history, how urgent or non-urgent something may feel. If someone is, if there's a couple in their 20s have been trying for 8 or 9 months and they're feeling the stress and fertility, it may be appropriate for them to talk to someone, even through telemedicine, and get some reassurance. And they may choose not to do anything in terms of testing or treatment, versus someone who is, 39 and has been told they have a diminished ovarian reserve. That person really may benefit from going ahead and being more proactive even now.
Great. So people are wondering about any additional risks if they do decide to move forward with the treatments, if there is something that comes up, such as ovarian hyperstimulation syndrome, where they may need
Mhm.
further medical assistance. And so what are those risks? And then how are they being handled now differently than usual?
Yeah, I mean, certainly this has changed a lot of how we practice. And so, for instance, we've done a lot more visits via telemedicine. Historically, insurance did not cover telemedicine visits. Now, many insurers have moved towards covering that, which has been great for a lot of us. So we're trying to keep patients at home as much as possible. But those of them who are undergoing treatment, we're trying to minimize visits, trying to minimize blood work as well too. For instance, if someone is undergoing an IVF cycle and has diminished ovarian reserve, they may not need blood work every single ultrasound visit as we would typically have done, during a more regular time. Certainly, we are trying to space apart patients in general in terms of scheduling. And we're taking precautions at the office in terms of screening all patients with temperature checks and questionnaires, and all the staff are wearing masks as well too. It's true that, despite our precautions, anytime someone leaves their house, they have some risk above 0% of being exposed to COVID, whether it be at the grocery store or the gas station or a physician's office. So we have to be aware there's no way we can 100% guarantee things. However, we do feel very safe and secure with the protections that we are taking. We understand that, two concerns that come up oftentimes are, what happens if I'm in the middle of fertility treatment and get diagnosed with COVID? I mean, it's true in that kind of scenario, we would have to cancel the cycle. And so we do talk to our patients, especially those of them who are considering IVF treatment, that if we had to stop in the middle of an IVF cycle, any kind of medications or ultrasounds they would have done up until that point, we would not be able to recover, so to speak. So there is, a possibility if someone is diagnosed, they may have to cancel in the middle of a cycle. And then another thing that comes up, especially with IVF, is, as you're mentioning, like, what happens if I develop ovarian hyperstimulation, which can be a concern in people who are young with higher egg counts. Again, we're taking precautions in terms of using lower doses of medication, watching patients with ultrasounds more carefully, using medications to mitigate and lessen the chance of that condition happening. Because there's no question that we want to minimize the chance that the patient would have to have an ER visit as a result of a fertility treatment. So sometimes things are unavoidable. We know that ectopic pregnancies can occur with or without fertility treatment. But we're doing as much as we can in terms of minimizing ovarian hyperstimulation, watching pregnancies early on, and trying to treat them appropriately if there's any concern for an ectopic pregnancy.
Okay, great. And that actually sort of leads into someone's question, which is, if I were to get a positive pregnancy test,
Mm-hmm.
what should I do next? Given that there's extra risk in visiting a healthcare provider, is it best to wait until 8 weeks? And this is if they do happen to fall pregnant at home before a prenatal visit. In other words, put off going to the doctor as long as possible. Do you have a recommendation around that?
That's a little tricky because it does depend upon someone's baseline risk. For instance, if they had already had a history of having ectopic pregnancy, which is a pregnancy that starts developing outside the uterus, they're going to be more at high risk than someone who has no risk for ectopic pregnancy. So someone who has a prior ectopic pregnancy, someone who has a history of pelvic infection, someone who has a history of tubal surgery, these are patients that are going to be at higher risk for an ectopic pregnancy, which, if it's caught early, can be treated a lot of times with medicine rather than surgery. So patients at high risk for ectopic, I would definitely recommend having them monitored either by their OBGYN or by us if they're one of our patients. For routine pregnancy, I would say it's appropriate for a patient to consider calling their OBGYN and getting more clarity from that person. Of course, the chance of ectopic in a person who has no risk factors is going to be pretty low. And so in most cases, there is not going to be a concern in terms of delaying a diagnosis. But again, occasionally, because an ectopic pregnancy is a kind of pregnancy that can lead to severe consequences, we just want to make sure those patients are watched more carefully. We are a little bit biased because infertility patients are a little bit higher risk for ectopic pregnancy because some of the things that cause ectopics can also cause infertility. So we are definitely pretty cognizant of that. But I would want to reassure people that for the most part, most people who are in early pregnancy, should consider calling their OBGYN and getting feedback from their personal OBGYN about what the recommendations are.
Great, great. So one person is wondering if you have seen any effect thus far on the stress of going through this pandemic on outcomes.
I think it's way too early to be able to see that so far. I think because we just, came upon this really in the last month or so. I know it's been in the news, obviously, for many months, but I think that many of us, we're thinking, oh, it's over there. It's in Asia. Okay, then it's in Italy. And then it's like, whoa, it's in New York. It's in, Seattle. So I think that the impact, we're not really going to see, the true impact we're not going to see for multiple months and even potentially a few years. I think that the sudden impact to fertility patients has been, oh my gosh, what do I do now? This is already challenging enough. And then I was hit with a pandemic. What am I going to do in terms of my fertility, my personal health, my job, my family, and trying to sort of juggle all those things. I think in the last few weeks, certainly in the Texas and Austin area, so far we've been pretty lucky in terms of the number of, cases, especially, cases in healthy people has been a very uncommon thing. Of course, I realize one of our challenges is that we don't have widespread testing, which I realize is a challenge. But I think a lot of patients are now saying, well, gosh, it's been pretty quiet for a while. And obviously the risk is still there. But now that I've had some more time to reassess, what my priorities are, we've had more patients, talking to us recently about wanting to have that visit, wanting to do some testing, wanting to take some control. Because I think that infertility already robs you of some control and the pandemic takes away more of it. And so in a sense, even though there are certain things we can't do in terms of going to the movies, going to a restaurant, those kinds of things, we can still gain some control in terms of information, and figure out a plan. It may mean doing testing now and treatment later. It may mean doing testing now and even treatment now. But at least getting information and making a plan with someone, I think, can be sort of therapeutic, especially in the scenario where we have lost so much control.
Absolutely. Yeah, that's a great point. So someone was wondering about if you could clarify when you say the woman is older,
Mm-hmm.
what exactly those parameters are.
Yeah, and this is not a hard and fast rule, but in general, we'd say that when someone is, the age of 35 or older, for fertility reasons or purposes, that's considered advanced age. Now, clearly, we've had many women who have conceived after the age of 35, many of whom have had no problems, and we've had patients in their early 30s or 20s who did have problems. So it's not an exact science, but especially by the age of 35, especially if someone wants more than one child, this is definitely a time to create a plan and to consider doing some testing to see where things stand currently and talking to someone who can explain the results of the testing and make a plan with that person or couple. I think would be very helpful.
Yeah, absolutely. And just to clarify, because somebody was wondering, you are taking telehealth consults right now.
Correct. Yes. And so the vast majority of our talking visits, consider talking visits like new patient visits and follow visits, are being done via telehealth. And I think that it's interesting because, one of the unexpected benefits is I think people feel much more comfortable talking about very personal things when they're in the comfort of their home. And there's something about having that separation that makes it a little bit easier for them to talk about things that are really, quite personal to them. So yeah, I think it's been an interesting, process. And certainly I think that that's going to be an enduring legacy of this. I think we're going to be doing much more telemedicine in the future, even when things, normalize. And I think that there is a lot of benefit to that. And so I think that, being able to speak from a place of comfort as much as possible, at least. I know that infertility stuff is really tough to talk about, but when you're in a more comfortable setting, I think it can be easier to discuss everything that's on your mind and not hold back.
Absolutely. And we found that as well, which is interesting because we're doing telehealth also. And
Yeah.
I would never have guessed at just how nice it's been and supportive
Yeah.
for people. So they actually did do a study that showed that even with telehealth, oxytocin is released which is the feel good hormone for both people.
Oh, really?
Yes, and the
That is
patient.
wild.
I absolutely think that we are going to see more of that down the road as well. So someone is also wanting some clarification around not only retrievals, but transfers and what your recommendation there is.
So yes, if we are in a scenario where we already have frozen embryos, yes, it's true that we have the opportunity of doing a transfer now or in the future. And it's true that success rate does not depend upon when we do the transfer. So if we are doing the transfer now versus 6 months from now or 12 months from now, there's no difference in terms of success rate. What can start happening over time is if someone is older, if someone is say 40 or 42, then waiting a year or two or more, it does, as we get older, we do have higher chances of diabetes with pregnancy and high blood pressure with pregnancy, as well as preterm labor. So if we're delaying for a period of time, we have to be aware those things can start becoming more of an issue. But yes, technically, we have had patients currently who have decided to proceed ahead, especially patients who may be in their late 30s, early 40s, and who would say simply, I want enough time to be able to complete my family. And so, yes, we can certainly proceed, but we've had other patients who've said, look, we want to sort of see how things, level out in the next few months or so. We're feeling like from a job standpoint or from a emotional standpoint, we don't feel comfortable proceeding ahead right now. And that's understandable. So we can go either way with that. But we know on the plus side, once we have the embryos, created and frozen, that we don't have the same time pressure in terms of doing the transfer itself.
Great. That's wonderful information. So there's also been some concern about what's going to happen in the future, and that there's some rumbling of a resurgence in the fall and winter. So do you have any thoughts about conceiving now and then potentially, if there is a complication with the pregnancy or being in labor down the road that people should take into consideration now while they're planning?
Yeah, and it's a tough thing because I think many of us initially thought, oh, there's going to be this peak and this fall and it's going to get better and there's going to be like a sweet spot again in terms of when it's going to be okay. And now, as you're mentioning, we are hearing reports that even there may be a resurgence in the fall and winter. We're hearing reports that this is likely going to be with us for some time, the virus in general. And certainly we're all looking for that vaccine. We're all looking for the treatments available, and we'll certainly have more tools over time. It's just, of course, unknown exactly like when we're going to be back to a little more of a stable position again. I think that, especially hearing about a possible resurgence in the fall and winter, it does make me a little cautious about pushing things off until then, because I feel like now summer may be a little better time, slightly speaking, compared to fall and winter. So I think that there's not a black and white answer, but I think this idea of just pushing a few months may not be as ideal as some people might have thought initially. And so we have to process information that we have right now and make the best decisions with what we have right now, and understand that if we start doing something and we're starting to hear about an increase, number of cases in the area, we've explained to patients, we may consider stopping a transfer process like before the transfer itself happens, if there is a concern of some kind of significant rise in cases in the area. So far, we haven't quite had that. And I know it's sort of been interesting because we've been sort of in this pause state for a while, like waiting for this big thing. And we're, of course, all on alert, and we will be continuing to take in information and processing it. But long story short, I think waiting a few months is not necessarily going to be that much better. It might actually be worse based upon, what they're telling us in science. I realize that when it comes to labor and delivery, it would be ideal to have a more, clear pathway, so to speak. So I realized that doing transfers in the summertime would lead to roughly, due dates in the early spring and such. I feel personally more comfortable with that than pushing the transfer off too much into the fall and winter, because I have a little concern about how things are going to be then.
Right. Yeah. And it's just so many unknowns at this point.
Correct.
And we know certainly less about this illness than we do know factually. Right. So someone is saying that they had COVID a month ago. Mm-hmm. And I could start my egg retrieval process in a few weeks, ? Or would it be better to wait longer? So this is somebody who's actually gone through COVID and now trying to determine the best time to move forward with their process.
Yeah, I'm assuming that their fertility specialist is probably going to want to have some kind of clearance from their either primary care provider or somebody else, because even though we're talking about COVID, we are not the experts on COVID. So before we would proceed with treatment, we would want to have some sort of PCP or internal medicine person or infectious disease specialist tell us that it's appropriate, to proceed. Okay. And that's to protect the health of the patient plus the staff and the other patients as well too.
Right. And so, and somebody also wanted a little bit more clarification about the process of the steps of actually coming in to see you, physically, and what that looks like.
Yeah. And so in terms of being a new patient, there are some similarities in terms of how it used to be, and there are some differences in terms of how it used to be. But basically, someone would call our office or use our online form to get a hold of our new patient scheduler, and they would then set up a telemedicine visit with one of us. There are 5 of us in the Austin area. And we'd have a visit typically with both patient and partner, if the partner is available or present, and talk about histories of the patient as well as partner, if there is a partner, and talk about some basic testing. Typically, in most fertility scenarios, there are 4 basic kinds of fertility tests, and they would include a sperm test, blood work for the woman, a fallopian tube test for the woman, as well as an ultrasound for the woman as well too. Now, currently, we actually don't have that fallopian tube test available. So we're sort of limiting things to those 3 tests, which are blood work and ultrasound and sperm testing if there is a male partner. And then typically after we get those results back, we can usually do that within a month. We have a second visit to talk about the plan. And that second visit can also be telemedicine as well too. Though the ultrasound visit would be an in-person visit because we have not yet figured out a way to do telemedicine ultrasounds. But in the blood work will also be an in-person at the local lab, which is CPL. The sperm test, if it's done, is something that the male partner would collect at home and drop off at the right time. at our facility. So typically testing can be done within a month, and then we have a second visit to make a plan. And when we're talking about a plan, our goal is to talk about, what is the success rate of different treatments? What are the relative chances of multiples? That's a pretty big one. What are the costs of things? And by the way, this is a good time to figure out, and if you've not already, what benefits your insurer may have in terms of fertility, because some insurers do cover some fertility treatments, many don't. But it still can be helpful to understand if you're needing to pursue any kind of fertility testing and treatment, where your insurer may stand. So it's basically like a 2-month process, with the first month being testing and the second month making a plan for next steps.
Great, good. So someone is wondering, what information do we really know at this point about transmission to the baby? Is there any risk to the child if you get pregnant during COVID?
Yeah, currently we technically don't know. We know that, this virus obviously is a pretty young virus, so to speak, and that was first described in the, fall. And so even patients who were early pregnant during that time in China have not necessarily delivered yet. So we really don't have a lot of information to go on. But currently, based upon the little that is known, there does not appear to be any kind of direct transmission of the COVID from a mother to a fetus. And yeah, there has been some concern possibly about some women who were infected with COVID during pregnancy, possibly having a higher chance of preterm delivery. However, it is not clear yet if those preterm deliveries happened as a result of COVID or something else. The challenge is we have so few patients to derive our information from that we cannot provide anything conclusively. And it actually will be a long time before we can really gather a good amount of information, because we want to have information not only about pregnancy, but also like childhood development and such, which will take a few years to compile. At least COVID is in a group of viruses that do not appear to have any kind of significant consequences on pregnancy, unlike, of course, Zika, which had horrible and devastating consequences. But we have to be honest that we don't have a lot of information, and so we are working with those limitations. And that is one reason why, again, some patients may consider proceeding with pregnancy currently, given this information and understanding there is some limitation of what we know, versus other patients who may choose to delay pregnancy until more information is known about COVID and pregnancy.
Yeah. Okay. And then for people who are delaying their treatments, what do you recommend they do in the meantime?
Well, there are a number of things that we can do, and I realize that some of these are not surprising, but just as a reminder, to optimize fertility, whether or not you're trying to conceive now or in the future, some basic things we want to consider. Number one, the smoking vaping thing. So as we all know, smoking is not good for fertility, not for women, not for men. We know that also it's important not only to not smoke, but not to be around secondhand or thirdhand smoke. So that means that not only do you not want to smoke, you don't want to be around someone who smokes, you don't want to be around in the environment of a smoky place like a bar or the place, I guess they don't really smoke in bars anymore, but anyways, places where there's smoke. So limiting exposure to cigarette smoke, vaping, not like limiting vaping for both women and men, recreational drug use. Definitely, there is evidence that pot use can lower the motility of sperm. We don't have as much information for women and fertility. However, we'd still recommend highly taking away recreational drug use, again, and vaping and smoking. Number two, moderating alcohol. For us, that would mean that for women, no more than 1 drink in a day, and that would be between the period and ovulation. And ideally, if the person is trying to conceive, then no alcohol after ovulation. For men, apparently 1 to 2 drinks a day is okay, but no more than that. No saving up for the weekend. Balancing body weight. People who are carrying extra weight or too little weight can impact their fertility. We know that body mass index or BMI is not a perfect way of assessing health, but in general, optimal fertility tends to be between a BMI of 20 and 25. And really, BMI starts to suffer in both men and women when it's above 30. So on Google, if you go to BMI calculator, you can calculate your BMI if you put in your height and weight to get a general sense of where you stand. But understandably, BMI is not a perfect indicator. For instance, we know like weightlifters may have a high BMI but still be very healthy. Other things, caffeine. Well, too much is not good. So we know that people who are having like 4 and 5 cups a day of coffee or caffeine, that can start impacting their fertility. So we definitely would recommend, cutting that down. That's for women. We don't really have good evidence for caffeine and impact on male fertility, but for women, we really recommend, moderating caffeine. Trying to get reasonable sleep. I realize it's easier said than done sometimes, but keep that in mind. And interestingly, exercise. We actually watch out for the heavy exercisers because that can start impacting fertility. So for our gals who are doing like marathons and really high endurance and high intensity things, that's great for their health, but that can start impacting their fertility because their body starts diverting energy away from reproduction towards basic life function stuff. So we would tell patients in general, like 4 to 5 times a week of exercise, an hour a day, medium intensity or less. And I would in general say, if you can talk with what you're doing, like talking in sentences, that's a pretty good indication that you're not at high intensity. But once you start gasping for words in between words, it's time to cut it down, at least for fertility purposes.
That's right. That's great. Yeah, the data is too little exercise is not good and too much exercise is not good. For sure. Yeah, that's wonderful. Yeah, we've been counseling people on how to stay the course and really use this time as an opportunity to prepare for when things do get back on track or when they're ready personally to engage again with their fertility, that they're even better off than when they started.
Yeah.
So, yeah, to just stay the course and this isn't like a no time at all. It's not wasted time. It can be valuable also, supporting
correct.
their. What's interesting is that I just saw today that there's a little bit of data coming out now about how people are getting sick and who's getting sick, and the people that have, for example, vitamin D levels that are more in an optimal range are faring better with the virus than people who don't. And just sort of we're in this weird little laboratory of where people are, we're getting all this information about how just being healthy impacts our lives, and that trickles down to our reproductive health as well.
Yeah, and it's interesting with vitamin D in general. Like most of our patients that we check their vitamin D level, they're a little deficient, and you would not expect that in Texas, especially with all our sun and such. But yes, we are learning more and more about vitamin D and fertility, but it's certainly an easy thing to add a little extra of, and easy thing to test as well too. So absolutely. I totally agree.
Yeah, that's right. I have a theory about why that is, other than that we're just inside all day anyway, but we always so much sunscreen. I put sunscreen on my face every day, so that might be contributing. But yes, it's like across the board very low. So is there anything else that you think would be valuable for people to know just moving forward? And if you can look in your magic ball and tell us where you see this heading, that would be great.
I think, as I mentioned before, I think knowledge and data is important. I think that for anyone who is concerned about fertility, I think it's always reasonable to talk to someone. And again, that doesn't commit you to doing testing or treatment. I think that, we are in a obviously this time has been so unprecedented, and who would have imagined on January 1st of this year that this year would have taken such a turn? And obviously we've had a lot of challenges thrown our way. They have come with some unexpected rewards as well too, like you were saying, in terms of this, at least for some patients, the ability and people's ability to take advantage of this time. I realize not everybody is in a fortunate position to have as much control. Understandably, there are people who are, working in pretty stressful situations right now. We certainly want to be cognizant of them as well too. But I think that this is going to shape us as a community, as a society, and I think that we're going to be in a much better place in a year. I think we're making decisions based upon the best information we have currently, there is not a one black and white answer that fits everyone again. But I think that if anyone is stressed or struggling about, concerned about their fertility, I think at the very least, talking to someone who knows how to counsel them appropriately can be helpful and can help them to empower themselves to understand where they stand and make a plan. And it may look different than they were intending, but at least having a plan, some kind of system or protocol, plan to follow, I should say, can be helpful in terms of regaining that, a little bit of that control again. And I think it can be very empowering.
Yeah, that's great. And it's such a unique situation that we're in right now, completely unprecedented. And each person's individual choice is also so unique to their circumstance, be it their personal health, where in their fertility process they are, what their lives look like, as far as how much contact they're having with other people and what their risk levels are, as well as what risk they're comfortable taking, when it comes to, like you were saying, early pregnancy or further on with some unknowns or with our medical system being stressed. So the very best thing that people can do is reach out, talk to you and your colleagues at the Texas Fertility Center, and then reach out to us at SAGE and get a sense of where you can support yourself from a holistic perspective so that you are going into this process armed with knowledge and with the best circumstance as possible. So I want to thank you so much for taking the time to speak with us all today.
Gotcha. Well, thank you very much for having me. I appreciate it.
Yeah. And we are announcing today also that we're opening a secret Facebook group so that people can find support in community with each other and with some guidance as well. So we're going to post that link down below. But that is a nice way to, in this time of isolation, to connect with people and feel supported and not quite so alone in this crazy process that we're all going through. So thank you once again. We very much appreciate your knowledge and taking the time to share it with us.
Thank you very much. I appreciate it.